Welcome to episode 5 of season 5 of the Fat Doctor podcast. I'm Dr. Ashalami, the host of this magical moment that we're about to embark on. For those who don't know, I'm a doctor. I'm also fat. I'm a fat doctor. I am the fat doctor, if you will. And today I'm going to be talking about chronic pain. This podcast is entitled, Yes, I'm Fat. Yes, I'm in pain. No, they're not related. Um, and those things are very true. I decided that I was going to be talking about chronic pain because it's a very common thing, chronic pain. It affects up to 40% of people worldwide. And yet, even though it's so common, and even though there are so many different ways to manage chronic pain, the vast majority of my clients are in chronic pain and are not being managed at all by their doctors. And I find that a bit baffling because it's not like their doctors have tried and failed, they just didn't try to begin with. And as a result, people, my clients, people I care about, are in agony and miserable and suffering and unable to sleep and unable to do the things they want to do. The joy is literally sucked out of their lives. Many of them are feeling like, you know what? I don't think I really want to be on this planet anymore, especially with a shit show going on around me. I'm miserable. I'm in pain. I'd rather not. And that's just not okay. That's not acceptable. That's there is no excuse for this kind of doctoring. So I thought I'd do a podcast episode about it. In fact, not just a podcast episode. I'm going to be talking about chronic pain all month. I have decided that this is chronic pain month. And one of the reasons I've decided that is because I am in chronic pain. It's official. Technically, for it to be called sort of classified as chronic pain, you have to have a constant or recurring pain in the same place for over 3 months. And back in November, so that's over 3 months ago now, I developed a condition called adhesive capsulitis, otherwise known as frozen shoulder. For those who don't know, it's a condition where you basically have inflammation and scarring in the capsule, the joint capsule of your shoulder. It becomes extremely painful, especially at night, and you can't move your arm at all, really. I have very limited range of movement in my arm. And you know what? That's very disabling. There are simple things that I am no longer able to do, like pull up my pants, brush my hair, not that I have much hair that needs brushing, thank God, lift something up, put something down, reach over to my left side, so it's in my left shoulder. If I've got a glass and it's over here on the left side, if you're watching me on YouTube, I can't actually move my arm, see, because it's frozen and it's very painful. And so, yeah, I'm experiencing pain, and I'm ashamed to say it is, well, ashamed, but I have always had an incredible amount of privilege when it comes to chronic pain and this form of disability, this type of disability, because it's not something I've ever had to go through. I have gotten through my entire life, apart from having 3 cesarean sections, 2 emergencies, 1 planned. I've never needed an operation. I've never broken a bone. I've never seriously injured myself. Like if I get pain, it lasts a few days. I do suffer with migraines, but not chronic migraines. So I haven't had to deal with pain every day, day in, day out. That is limiting my ability to function. And the one thing you have to understand about chronic pain, by its very definition, it's not just the physical sensation, it is also the emotional sensation too. That actually, in the actual definition of pain, involves both physical and emotional. And I also think should be social because it's very limiting, isn't it? So here we are. I guess it's a bit embarrassing that it took me until I developed my own pain to start talking about this, which is not entirely true. I have actually done masterclasses on chronic pain in the past, and I have talked about various types of chronic pain. But yeah, let's get into it. So I don't know about you. You may be listening and go, I'm pain free, and that's fine. But even if you're pain free, you've probably experienced this with other symptoms. You go to your doctor. And before you can even describe your symptoms, before an examination takes place, before any investigations or blood tests or anything like that, your weight becomes the primary diagnosis. This is a weight problem. You haven't even explained. Actually, my shoulder, Adhesive capsulitis, nothing to do with weight. Might be linked to the fact that I'm in my 40s, might be linked to the fact that I am a female by birth, might be related to the fact that I'm diabetic, but actually has nothing to do with my weight. And yet, pain is almost always blamed on weight, doesn't it? Doesn't matter if you're dealing with frozen shoulder or migraines or nerve pain or even post-surgical complications. God, even cancer pain still gets blamed on weight, and that is disgusting. How it's magically just, in fat people who are in pain, it's a weight thing, and thin people who are in pain, something else. I don't understand. I'm not even going to attempt to. But this isn't healthcare, folks. This is medical gatekeeping. We're literally gatekeeping painkillers. And we wrap it up in this kind of very thin veneer of concern, but we're concerned about your health, we're concerned about your weight, and so we'll use this opportunity right now. You're sitting in front of me, you're in pain. The last thing you need to really discuss is your weight, but we'll use any excuse to tell you that you're fat and that you need to eat less and exercise more, or maybe go on weight loss medications, or maybe even consider bariatric surgery. We have to get that out. It's like a compulsion, and by we I mean doctors. So there are already, see, the thing about chronic pain is there are already a whole bunch of assumptions that your healthcare providers are making, right? The first assumption is you're overreacting. It's really not as bad as you're claiming that it is. The second assumption is that you're just inactive. If you moved more, if you were healthier, you were and I put that in inverted commas, but I can't do it properly for those who are watching because you can see because I can't move my fucking shoulder. Anyway, moving on. This is not about me. So you're overreacting. You're too inactive. You're drug seeking, especially if the painkillers like acetaminophen, Tylenol, paracetamol, whatever you want to call it, and or non-steroidal anti-inflammatory drugs, if they're not working, then you need opioids. Oh, you're drug seeking, which is really not the case at all for the vast majority of people. I mean, you are opioid seeking because opioids are painkillers and you're in pain. So in a way you are, but that doesn't mean you're addicted to them. And it doesn't mean even if you are addicted to them that you shouldn't have them, right? You shouldn't be having prescribed opioids for recreational use, but you absolutely can and should be given opioids for pain relief because that's the indication for prescribing them. It's literally what they're designed for. Anyway, so you're overreacting, you're too inactive, you're drug seeking, or you're just not trying hard enough to get better. If you just try harder, do something about it. Why are you bothering me with your chronic pain? That's the kind of bias that you are kind of being confronted with, regardless of your size, right? But then the size adds another layer. Also, by the way, you're fat and lazy and incompetent and just basically want to, what is it that they'll be assuming? Want to just live off benefits, just take drugs, snort opioids and live off benefits, clearly because you're fat. And yeah, folks, can we not stereotype people who are dependent on opioids either? The opioid epidemic is the result of an extremely despicable family of people called the Sacklers, who took a drug called oxycodone that really had no business being used ever because it was fucking useless is what it was. It was a useless drug. There were much better drugs out there. And because of their amazing PR and because of the money they spent on it, we now have a Purdue Pharma induced opioid pandemic because of one greedy fucking family, not because of drug users. So can we stop blaming them? But that's a sidebar. Um, Anyway, where was I? So, like I said, they're going to make assumptions about you anyway. But if you're fat, it's worse, and it's worse on a multitude of layers because every time a fat person is denied proper pain management, it reinforces the medical trauma cycle. And by that, I mean you're already being traumatized by your doctor, and this is just one extra trauma every time you go to a doctor and you're being denied uh, pain relief. So as a result, we delay, as fat people, delay seeking care because we want to avoid the shame and we want to avoid the discrimination. But as a result of that, our pain becomes more severe and disabling because we're not treating the problem. And even if it's not treatable, we're not getting adequate analgesia. And so every single negative experience adds another layer of trauma until avoiding healthcare altogether seems like the safest option. And then we get sick and people blame our weight. It's not the weight, it's the weight stigma, folks, and the medical trauma cycle, which I'm, a term that I don't know if I've coined it, but I am now going to be using on a regular basis. So we already know, right? I mean, you're probably living under a rock if you don't know this. There is a huge amount of statistical evidence that doctors are denying Black people pain relief. Like it's well documented and it's disturbing. If you actually look at the statistics, you're like, holy crap. That's not just a little bit, that is profound and is historical, has been going on for centuries as a result of anti-Black racism and is despicable. There is no place for anti-Black racism within the medical community, and yet the medical community is rife with it. We already know this, right? We don't have as much data when it comes to fat people being denied analgesia, but the data doesn't exist. But there's two things I'd like to remind you. First of all, you'd be Black and fat and being denied painkillers. Second of all, that racism is the root cause of fat phobia. For those who don't know what I'm talking about, you need to go and read Sabrina String's book. You need to read Deshawn Harrison's book. I will link them in the show notes. Fearing the Black Body is Sabrina String's book. Oh my gosh, I'm having a brain fart moment. Deshawn's book is amazing and is called This is what happens. Sorry, Deshawn, if you're listening. Anyway, linked in the show notes. It will come to me in about 10 minutes. Don't just wait and see. The politics. It's not fearing the Black Body. It'll come to me. Anyway, so now racism is the root of fat phobia, and therefore I think if we were to try and collect the data, we'd probably find that analgesia is denied to fat people. We certainly found that other forms of treatment are being denied to fat people. There's plenty of data to support this. So I'm going to put it out there based on my clinical experience, based on your collective experience, based on the things that I've seen. I think it's fair to say that there are massive disparities in pain management for higher weight patients. And there, there is literally no evidence that being fat causes pain. Okay, so there's no justification. I don't want to hear anything about weight on the joints. I don't want to hear anything about leptin levels, and I don't want to hear anything about chronic inflammation. Please, if that's where you're going, shut the fuck up, and also go back and listen to some of my previous podcasts. I've covered this in great detail. Chronic inflammation does happen in fat people. Raised leptin levels does happen in fat people. Weight on the joints, I'm not even going to entertain this stupid thing. But the other two, yes, that is true, but just that doesn't necessarily mean it's anything to do with being fat. It could just as easily, more importantly, most likely be to do with weight stigma, weight cycling, and the stress of navigating a world that hates you because you're fat. So please don't come to me with leptin and inflammation and stuff. That's not it. That's not it. Thin people get chronic pain all the time. If it was because you're fat, then no. There are actually there's three main actually reasons why people get chronic pain. Right? The first, and I'm going to give you the technical names here. The first is nociceptive pain. That's from tissue injury. So if you've damaged yourself, you've been injured, then that's nociceptive pain. The injury itself is causing pain. Then there's neuropathic pain. That's from nerve damage. So if you've got actual damage to the nerves are responsible for your experience of pain. So if they're acting up, then you'll be experiencing pain, even though there isn't any tissue injury. And then there's nociplastic pain. And we never talk about this. But this is actually responsible for a lot of chronic pain, which is basically your nervous system becomes sensitized. We don't know why, but your nervous system becomes sensitized, and therefore you experience pain at a higher level. And, people are always like, oh, you just got such a low pain threshold. Yes, it's called nociplastic pain. Okay? My nervous system is sensitized to pain. Well, I don't know why, but it is. So stop acting like it's somehow my pain threshold is under my control. No, it's not. It's my nervous system. I don't have control over that. So those are the three types of pain. And can I point out that oftentimes it's at least two, sometimes even all three of those things that are going on. Also want to point out that you don't have to have tissue injury in order to have pain. Okay, that's another really important thing. Pain, when we treat pain, we talk about the biological, biopsychosocial model. Chronic pain has three main elements: the biology, so nociceptive, neuropathic, or nociplastic, the psychology, and the social element to pain. And it's complicated, is what I'm trying to say. Usually, acute pain, if you just get pain out of the blue, it's usually a very simple response to an injury of some kind, right? You touch a hot plate, ow, you get pain. Someone punches you in the face, ow, you get pain. You got a massive spot or boil forming, ow, it's painful, it's an infection, it hurts. You just had surgery, ow. You broke your leg, ow. You turned your ankle, ow. Yeah, it's normal to get acute pain as a result of some kind of injury. But chronic pain doesn't require an injury in order for you to experience it, right? In fact, oftentimes chronic pain isn't linked to an injury. Um, and so that's really important to remember. In real life, how this basically manifests is doctors are already primed to deny your experience of pain, to not believe you, to assume that you're lazy and not trying hard enough and all of those things, drug seeking, all of those things. And if you're fat, well, they already have prejudice against you. They already have very negative stereotypes and attitudes and beliefs about you. So that just kind of makes things worse. I can't think of the word there. It just makes it worse, right? It doubles it, triples it, impacts it exponentially. So I want to, instead of just telling you how shit the world is, because it is shit, and many of you who are in chronic pain are very aware how shit it is, I want to talk to you about solutions. I want to talk to you about the path forward. I want to talk to you about what to do if you find yourself in this situation. If, like me, you have chronic pain and you're a fat person, you're thinking, what do I do? So, first thing I need you to remember is pain does not require, as I said, an injury or visible tissue damage or a pathological finding to be real and valid. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience. Unpleasant sensory and emotional experience. Very clearly states that there is no requirement for proof on an MRI scan or an X-ray or a blood test or an examination even. There is no requirement for proof. If you say you're experiencing pain, then you are experiencing pain. Your pain is real because you experience it. Full stop. So when you say I'm in pain and a doctor says there's nothing wrong with you, they are gaslighting you, literally, quite literally gaslighting you, because you're saying this is my experience and the doctor is saying, no, it isn't. What the doctor means to say is, I have not found any reason for your pain. I have not found any reason on my scans for your pain. But that shouldn't matter. Because chronic pain in of itself is a diagnosis. In fact, if you go to the ICD-11, the International Classification of Diseases version 11, which is the WHO, the World Health Organization, international classification, right? If you go to ICD-11, if you go to MG30, you will find all the different codes for chronic pain. Chronic cancer-related pain, chronic post-surgical pain, chronic musculoskeletal pain, chronic neuropathic pain. Like there are all these different types of pain. That's a condition in of itself. So says the WHO. So when a doctor says to you, there's nothing wrong with you, that's not true. The issue is pain. That is my diagnosis. So says the International Association for the Study of Pain, and that definition has been sort of accepted, broadly accepted throughout the world, including by the WHO and pretty much every other organization. Certainly in the UK, the National Institute of Clinical Excellence uses the IASP definition of pain. So, first things first, Going forward, if your doctor says there's nothing wrong with you, you say, no, my diagnosis is chronic pain. In fact, you can ask for a specific diagnosis. You can even ask for the code for that specific. It's got a number, letters and numbers. As I said, MG30. That's where you need to be looking. And I've done a video on this specifically on chronic pain and the classification of chronic pain. And if you're interested, that's part of my fibromyalgia masterclass that's coming up this month. Yeah. I literally go through it step by step. And so you can find out and you can look it up yourself. This is the pain that I have. This is the diagnosis. This is the condition that I have. And you can put it on my medical history and you can code it on my medical history. Please, I don't care whether you found something on my MRI or not. I am in pain. The end. All right. So I need you to know your rights. If you have a medical condition, you need to know your rights. Number one, you have the right to a proper pain assessment, a history, an examination. Number two, you have the right to appropriate pain medication. If you have a diagnosis, a diagnosable condition with a code, then your doctor is obligated to treat that condition. Right? Now, there are some cases where there is literally no treatment available. For example, if you have terminal cancer, we might say to you, look, there's no, well, that's not true, actually. We wouldn't be saying that because, of course, there's treatment available, palliative treatment. I'm trying to think of, maybe there isn't. But anyway, I went off on a little tangent there. Let's get back to it. If you have a diagnosis of chronic pain, then you have the right to treatment for that chronic pain diagnosis. And I know this is going to sound a little bit simple and basic, but I am a bit of a basic bitch. When you have chronic pain, the mainstay of treatment is to treat the pain. And we do this in two ways. One is to find the underlying cause of the pain and treat that. And two is to give you painkillers for the pain. I know. It's going to come as a real revelation to some of you, especially healthcare professionals who are listening in right now. Can you imagine? Someone's in pain. Two very simple things to do. One, find out what the cause is and treat that. But if you can't, doesn't matter, because the other option is number two, treat the pain. And whilst you're looking for the cause, treat the pain because the person is in pain. You don't get to just ignore the pain because you don't like it. You can tell that I'm very angry right now. I just want to point out my doctor is amazing at treating my pain. My doctor has not let me down yet. I'm very lucky I have a good doctor. Also, I'm very privileged because I am a doctor and doctors tend to be nice to other doctors. Also putting that out there. So you have the right to a pain assessment. You have the right to pain medication. You have the right to a thorough physical examination. In fact, I'll take it one step further. If you go to see your doctor and you say, I have pain, and the doctor doesn't touch you, and by touch you, I mean examine your pain, then that is a negligent doctor. Don't go back to see that doctor. Put in a formal complaint about that doctor because that doctor has been taught from day one in medical school. History, examination. There's never an excuse not to examine a patient. Now, that just universal. Examine the damn patient. So you have the right to proper pain assessment, pain medication, a thorough physical examination. You also have the right to refuse weight-related discussions. I do not consent to discussing my weight or weight loss during this consultation. The end. You also have the right to a second opinion. Everybody has the right to a second opinion. I understand that insurance companies can get in the way of this sometimes, but you are entitled to a second opinion. And if you tell your doctor, I want a second opinion, your doctor is obligated to refer you for a second opinion. So that's your rights. Now you know your rights. Here's what I think that you should do. Okay? If you've got chronic pain, you're going to see your doctor. The first is that you need to demand a proper assessment. So if your doctor is not paying attention or not really willing to listen to you and jump straight into the diagnosis, oh, well, you know what that says. You can say, sorry, could you first assess my symptoms? Can we first discuss my symptoms before you draw any conclusions? You can absolutely say that. Can we discuss my symptoms before you draw any conclusions? Otherwise, that doctor is just prejudging you, and that's not okay. You can ask for a physical examination. If your doctor isn't examining you, you can say, are you not going to examine me? Just that simple. Are you not gonna? You can ask for appropriate blood tests. And if your doctor says you don't need blood tests, you can sort of say, well, can you tell me all of the things that this could potentially be causing your pain, my pain? Just all of them. Can you list them all? And then ask them to list them. And then say, well, how are you ruling all of those out? Because in my experience, in chronic pain, not acute pain, as I said, acute pain is usually a response to some form of injury. If you twisted your ankle is swollen, I have examined you and I've gone, yeah, I think you sprained your ankle. I don't think you need an x-ray. I don't think there's any evidence of a break, of a fracture, although that's, no evidence of a fracture. You don't need an x-ray even. Here's what you need to do. Ice, elevate, da, 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 da. I'm not going to offer you a blood test for that. That's an acute injury. But if you come to me 3 months later and your ankle is still painful, you're damn right I'm going to offer you a blood test. Also, I hope you came to me before the 3 months. But anyway, because I would have told you that you can't wait 3 months. But whatever. Um, so yeah, blood tests in chronic pain, I would argue, are essential. Imaging is essential. If you've had pain for 3 months and we don't know what's causing it, we need to do some kind of imaging to figure out what's causing it. Imaging like an X-ray or an ultrasound or an MRI or whatever, or like if it's abdominal pain you're getting, then maybe we're thinking about endoscopy, but we're going to do some kind of investigation at this stage, right? So a discussion of your symptoms, a physical examination, appropriate blood tests, appropriate imaging. And then when we get to the treatment part of the consultation, right? A discussion of all your treatment options, all of them. And by that, I mean there is more than one, because one treatment option is do nothing. So there's at least two, but there should be several. What are all my treatment options? Can you lay them out for me? What are all of them? And then here's the thing, and I really think this is important. When you are at a doctor's appointment, bring a notebook and take notes. You are absolutely allowed to do this. You can also record the consultation. In places like the UK, it's absolutely legal to record the conversation. You don't even have to let your doctor know. But if you say, I'm going to record the consultation, your doctor can't say no. Like by law, they're not allowed to say no. What you do and how you distribute this is different because obviously your doctor is entitled to privacy, right? So you can't just go play it on the internet. But if you record the conversation for your notes, and if you then take that conversation and transcribe it, that is a matter of record between you and your doctor, right? So if there was a situation where your doctor was like, I said this, and you're like, no, you didn't, but you have the recording and you have proof, right? Not to share with other people, but if there was, say, a complaint process or whatever, you have proof, right? Is what I'm saying. So you can absolutely record the consultation. You can also write notes in the consultation, and I strongly suggest that you do. Because then when you say to your doctor, what are all my treatment options? You write them down, right? Just write every single one of them down. Let your doctor know you are paying attention and you know your rights. You need to be given all of your treatment options. And if you have refused consent to discuss weight or weight loss, then they don't even mention your weight. If you haven't, they may offer weight loss as a treatment option, but it is not the treatment option. As you know, I do not believe weight loss is ever a treatment option. And I'll get to that in a moment. But this is really important. Okay, I got a bit lost. Keep a pain diary if you can, or some record of what's going on, because again, that's really useful. Um, Record all instances of when care was denied or delayed. If your doctor says, I'm not going to treat you, write that down, record it, keep a note somewhere, keep record somewhere. Ideally, all your medical records, all your correspondence, everything should be filed away because it's there as proof that you are not receiving the treatment that you should be receiving. And if we decide down the line, if you decide that you want to take this further, lodge a formal complaint, even if the legal, the legal proceedings need to take place, usually not necessary, but if that is the case, you have it all documented. Make sure you keep notes, keep a pain diary, record all the instances where care was denied or delayed, save all of your medical records, save all of your correspondence. Okay? That's my resources for patients if you've got chronic pain. If you're a medical professional and you're listening, or maybe you're not a medical professional, but you deal with fat clients who are experiencing chronic pain and are being denied care, and you're thinking, well, what can I do to support my clients or my patients? Well, first and foremost, thank you. Second, this is now more about how we are going to collectively advocate for the fair treatment of fat individuals. So one of these things is about unlearning and learning, right? So there's a piece here about education. But there also has to be some form of collective action. If you're sitting here listening week after week and going, oh gosh, you know what, Ashley, you're so right, but you're not doing anything about it. I get it. You're probably very busy. And I'm not saying that you need to drop everything you're doing and like focus on this. There are so many issues going on in the world now, and we cannot spread ourselves too thin, and we cannot break ourselves up into lots and lots of different pieces. And actually, our piece is most important. Protecting our own peace, rest is resistance, all of that stuff. But it is also possible to challenge these institutions when we work together collectively. And at this, in such a time as this, I don't think there's ever been a stronger call for us to work together collectively. Ooh, pardon me, collectively. Um, so you can join me in the waiting room, which is my community. Whether you are a fat patient or a fat provider or just a provider that cares about fat patients, the waiting room is a safe space where we can come together and support one another through life by making connections, but in particular when it comes to weight inclusive care and fighting against weight stigma. It's only £15 a month. You get lots of wonderful things, including what I've dubbed clinic hours, which is time to spend with me. So if you've got any questions, concerns, like, you need some advice, come to me during clinic hours, and you can do it face to face. You can do it via private DMs. You can do it in a group chat, whatever. However you choose to access clinic hours, spend some time with me. Ask me some questions face to face. Yes. Um, I'm also, as I said, I'm doing a fibromyalgia masterclass, and I will be including a lot on chronic pain. So if fibromyalgia, by the way, a very classic example of nociplastic pain. In other words, fibromyalgia is almost certainly linked to a sensitization of the nervous system. And there's loads of fascinating information about what causes this in fibromyalgia. So really good one. Fibromyalgia is also one of those conditions that is kind of like, we're not sure what's wrong with you. You've got chronic musculoskeletal pain. We don't know what it is. It's fibromyalgia. Oftentimes it is fibromyalgia, sometimes it's not. So I will be covering all of that in my fibromyalgia masterclass. If you are a healthcare provider, I very much recommend that you join. You get access to lots of resources. Join the monthly masterclass membership, and you don't just get access to the fibromyalgia masterclass, you get access to all my masterclasses. And then if you're struggling to get the kind of care that you need, as I said, join the waiting room. So if you are not getting pain relief and you need pain relief, join the waiting room, please. I am going to be offering a free pain consultation, chronic pain consultation, to everyone who joins the waiting room in the next 2 weeks. So if you're in chronic pain, you're listening to this right now, you're like, oh, I'm in pain, I need help. Join the waiting room and you get a free pain consultation with me, obviously. Yeah. All right then. I don't know how long I've been talking. Couldn't tell you. Hopefully it's long enough. I hope you find that helpful. Chronic pain sucks. I will be talking about it, as I said, for the rest of the month. And so excuse me. Come back and we'll talk chronic pain. And I've also written a lovely blog post about it. So you can go to my website and you can check out my blog post. I can't remember what it's called, but it's the most recent one anyway. And you can also ask me anything. Remember that you can ask me absolutely anything on a Wednesday on Instagram, or if you want me to answer your question here in this podcast, then you can absolutely do that too. of asking me anything. My last Ask Me Anything on Instagram, unfortunately, I messed up and I lost some of the messages, and I'm going to cover them this week, but I'm going to use one of them as my for my podcast as well. I can't remember what I'm calling this segment now. That's really embarrassing. Is it Ask Me Anything? Probably. Anyway, here's one that I thought I'd talk about on my podcast. I'm a fat person with an eating disorder. How do I get the NHS to take my weight loss seriously and stop praising it? So, first of all, doctors don't believe that fat people can have eating disorders, do they? I was watching a TV program the other day, a really good one. It's called The Good Doctor. I don't know if any of you are watching it. I don't watch medical programs normally, but because it's about an autistic doctor and we're an autistic family, we've been watching it as a family together. And there was this awful episode in season 1 of The Good Doctor where they had 2 patients. One was a man who had had bariatric surgery and didn't want to tell his husband that he'd had previously had bariatric surgery, especially now that it was having to be reversed. He had all these complications. Well, he was diagnosed with Crohn's disease after bariatric surgery, far less likely than the fact that he probably developed lots of ulceration after bariatric surgery, which is normal or common, I should say. Anyway, that wasn't the bit I was talking about. It's actually the eating disorder one, which again was a thin white woman who had an eating disorder, and that, of course, is what we all believe an eating disorder looks like. And it's something that Leslie talked about a lot in last week's episode. Hopefully you've watched that by now. So fat people don't have eating disorders, right? I'm saying that sarcastically, of course they do. And in fact, the evidence out there shows that fat people are some of the most common people to have eating disorders. And in fact, thin people only make up, I think it's about 6% of all people with eating disorders. And no, when I'm talking about eating disorders, don't assume, oh, if they're thin, they have anorexia, and if they're fat, they have binge eating disorder. That is not the case. I'm talking about restrictive, all eating disorders are restrictive, but I'm talking about anorexia diagnoses, very common amongst fat people. Although, of course, it's difficult to diagnose because, if your BMI is high, you're not starving yourself. Gosh, I'm being a bit bitchy and passive aggressive, aren't I? So your question was, how do I get my doctors to take my weight loss seriously? And you didn't specify whether the weight loss was part of your eating disorder. Unexplained weight loss or intentional weight loss as part of an eating disorder, both of these things are always a red flag symptom. Always. When you study medicine and they tell you about weight loss, it's never a good thing, except for when we're fat and you're trying to make them lose weight. But unintended weight loss or weight loss as a result of an eating disorder is never a good thing, ever, ever. There is no caveat except for in fat people. It's just ever. There's almost universally a sign that something is happening. Something is going wrong. Your body holds on to weight. It doesn't let it go unless something's happening. It could be something pathological. It could be something psychological in this case. It could be all sorts of reasons, but it's never something that we should be celebrating or ignoring. So I think, this is a complex question to answer, but I think first and foremost, you need to be very direct with your doctors. Why are you celebrating my weight loss? This is not intentional. This is part of, and then you explain what you think it is. This is a psychological, psychiatric condition. Why are you celebrating my weight loss? Do you want me to die? And you can be really like, are you hoping that I'll die? Are you hoping that I'll come to harm? Why are you celebrating it? I would be very direct. I would be very direct. And if you don't feel like you can say that, then I suggest you bring an advocate who can. An advocate who will literally turn around and ask the question, I don't understand. Why are you celebrating this? Isn't this something to be concerned about? Are you just hoping that they'll die? If you need more support, then please feel free to come back to me. But yeah, hopefully that answered your question. I probably should have put a content warning there, but then to be quite honest, I think we all know by now that content warnings part of the course in the Fat Doctor podcast. Everything you've been told about weight loss is a lie. You know that, don't you? And that is a segment. I'm trying to, I was trying to find this earlier and I had to press pause. I'd lost my I'd lost it, and now I've lost it again. Damn it. Here it is. I am going to be talking a little bit about leptin here because I mentioned leptin. Leptin gets brought up a lot um, by health professionals when we talk about chronic pain. Oh, it's leptin, it's leptin. And leptin, of course, is higher in fat people, so it's leptin. That's what it is. So I'm taking this from the paper title Leptin Resensitization, a reversion of leptin-resistant states. Now, a bit of background, leptin is higher in fat people. There is a general belief now that fat people have become resistant to leptin. I cover this in more detail in No Way Chapter 3. But yes, there is most likely some kind of resistance to leptin, most likely caused by weight cycling, although that never gets brought up in the literature. But anyway, if you are resistant, you can become resensitized to leptin, and that's what this little article is all about. And it very confidently states, possible. If you lose weight, you'll become resensitized to leptin. And I have some issues with this article. Number one, there is another state where you can become resensitized to leptin very easily, and that is pregnancy. We all know that leptin resistance is common in pregnancy, and when you stop being pregnant, then the leptin resistance stops and you are resensitized to leptin. So it can just happen naturally. The second is that this idea that we can change it just by losing weight, and they'll quote all these studies, they're all based on rats. I looked at all the studies they looked at. There was one study, it was all about sleeve gastrectomies. I was like, oh, they've shown that if you have bariatric surgery, then it will improve your leptin resistance. I didn't know that. Have I been wrong all of these years? My goodness. I'm so terribly sorry, people. I'm going to have to make an announcement. Bariatric surgery does improve your leptin resistance. Oh, wait. No, these were rats. Um, yeah, that's no good, is it? Um, It's other studies, not on rats, on mice. It's, there's that too. Um, there aren't any human studies. Gosh. And the ones that were human were very short term. We're talking a matter of days, weeks, no longer than that. So when somebody says to you, ah, it's a leptin issue, you can be like, it's probably not. Well, chronic pain, it's all related to leptin. And then you can say, so what do you want me to do about it? And they'll go, well, lose weight and you can, become more sensitive to leptin. And you can say, really, where's the evidence to show that? Because last time I checked, all you have are rat and mouse studies, and none of them last more than a few weeks. So shut up, please. Until you have actual evidence, don't waste my time. Hopefully that helped people who are more interested in the research. This paper was by was it 2019 Andreoli, I believe, et al. I will link to it. It's extremely fatphobic, horrible, stigmatizing paper. So please don't read it unless you're fascinated in mice and rat studies. But just to let you know, next time someone says, "Oh, it's all about leptin," you can go, "Yeah, no, it's not," and then you can send them that paper and be like, shut up. Okay, well, that's that. I'll see you next week. As I said, I'll be talking about chronic pain all month. Join me in the next episode.